like gangrene in his toe and getting really like black and, just nasty. And every time he came to the hospital, the surgeons were like, look, mate, we need to cut your toe off. They're getting him from the ambulance stretcher onto the hospital bed. And I kid you not, when they moved him across, his toes fell off.
Oh my God. No.
What do you desire? What would you like to do if money were no object? How would you really enjoy spending your life?
Welcome to another episode of the Learning Through Life podcast. I'm your host, Nathaniel, and today I'm speaking with Dr. Daniel Szechuan. Daniel has been working as a doctor in hospital emergency rooms for several years, and in this episode, he shares what day-to-day life is like as a doctor, his most scary and unbelievable moments, as well as the challenges he and many other doctors faced during COVID-19. We cover more topics around COVID-19 controversy, the healthcare system, and the importance of finding something you love to do outside of work in order to live your happiest life, as well as living to enjoy the present moment, because life as we know it could be taken away from us at any moment. I now present to you Daniel Szechuan. So then what, after Japan, what's next for you? Back at work?
Well, then I'm actually starting my advanced training. So well, for anyone listening, I'm a doctor. So yeah, I've been I've been. Well, I'll say a quick rundown. So yeah, I graduated uni in 2018, and then did 2 years at Frankston Public Hospital, just as a junior doctor there, and then basically, so the second year of that was 2020, which was obviously a pretty wild time, and I was pretty just feeling really burnt out and over it after that. So then Chloe and I took off in this little caravan that I'm in now. We did this up and went over to WA and hung out in South Oz, WA for like 6 months. And then we came back, and after that, I've started doing emergency department work, but kind of like as a subcontractor doctor or a locum doctor is like the other term for it. So I've been doing that for like 2 years, but generally speaking, as a doctor in Australia, like at some point you'll do advanced training, which is like after you finished uni, and it's kind of like an apprenticeship, I guess you could say, to become like qualified as a specific type of doctor or specialize, as you might say.
Yeah,
so,
right.
for example, what I'm going to do is I'm going to do GP training, which is like one of the shorter training programs. So, if you pass everything and you've done all the prerequisite stuff, it takes about 2 years to do it. And yeah, so I'll be working as a GP for 2 years, and kind of like learning on the job. And there'll be like a supervisor around that I can ask questions to and stuff if I get stuck. And then at the end of that, like you sit exams, and assuming you pass all of those, then you're a GP. So I'll be doing that for the next 2 years. And then, whereas like, if you wanted to be a surgeon or something, then it's like similar, but like they all have their kind of quirks. They're different times when you have to sit exams and different hurdles that you've got to jump over and stuff to move on to the next step. But GP is like, I mean, people still fail it, but I think it's relatively, it's definitely quicker. It's only 2 years. And I think it's relatively easier in terms of the training pathway and stuff. Yeah. So hopefully it'll all be done in 2 years if everything goes well.
Yeah. So actually 2 questions. First of all, like why did you decide to be a doctor? And second of all, why then pick GP out of everything else that you could have chosen?
Yeah. So when I first during high school, I guess I always kind of found science subjects pretty interesting, and then was pretty good at it at school too. So, and then I think as I got sort of towards the end of high school and it kind of becomes a little bit more detailed, the stuff you're learning about, I found the like biology side of things more interesting than the other stuff. Like, didn't really like chemistry that much. Physics was pretty cool, but like, I'm not like a maths person. I can do it, but I'm not like, I'm not
Okay.
crazy about it. Like, yeah. So it seemed to me like, yeah, something like more biology related was more sort of up my alley. And then I sort of got thinking a bit more sort of seriously towards the end of year 11, and just kind of, I guess I just kind of had to think about what maybe my strengths were and stuff, and I realized I was more, and also just the sort of lifestyle I wanted to live, and I realized I'm
Mm.
more of a people person. Like, I wouldn't do well like being in a lab or something running experiments. I'd get really bored. I'm more of a I like interacting with people more. So
Yeah, yeah.
there's that, and I also liked the idea that as a doctor you're very flexible in where you can live. Like I was I didn't really know exactly why or like where I wanted to be, but I knew that I would really like to have that flexibility to be able to kind of
Mm.
work in various places and not just have to work in like a big city if I didn't want to. Because I mean, I was
Yeah.
only like 17 and from like a little country town, so I didn't know if I was going to like being in the city. I was like, it'd be cool to be able to move back out to the country if I wanted to later. So with all those
Yeah.
things together, I kind
Do you
of thought that medicine would be a good fit for me. Yeah.
Nice. Do you think there's like, because I feel like when I think of like doctors and shit, I just feel like they would have to be some sort of like type of person to be a doctor. Like, do you think there's like a type of person that you'd have to fit into, like in the world of being a doctor? Like, what are some like common things you feel like most other doctors and yourself probably share?
Yeah. That's an interesting one. I think, to be honest, no. I actually think um, medicine is probably one of the. It's a cool career in the sense that I feel like there's kind of something for everyone. Like if you're someone who's really likes, talking to people and solving puzzles, that sort of thing. Um, there's kind of stuff for those sort of people. Like, they could be a psychiatrist or a physician or something if they like really complicated sort of problems and talking to people, getting to the bottom and solving
Mm.
puzzles. And then you've got, people who are more sort of hands on and more practical and sort of that kind of thing. They might be more like, they might then trend towards like surgery, becoming a surgeon. Then you've got, people who are sort of more, they just want a lot of variety and like lots of different stuff and like a lot of human interaction. That would be like the emergency department or I guess GP as well. Um,
Mm.
and then like if you realize that you're actually terrible at talking to people and hate dealing with patients, then you could become a radiologist or something and just report CT scans and MRIs and stuff. Um, so there's kind of something for everyone. Um,
Yeah. Okay.
so I would say no. I don't think there's anything like particular personality type that's like
Okay.
needed to be a good doctor because there's kind of something for all different sorts of people. But what I would say is that because medicine is so hard to get into, that sort of does select for a more I don't know, that term like type A personality or just like people who are yeah, just really sort of rigid and driven and like disciplined and because the reality is like if you weren't able to do that at some point in that age between like 18 to 21 whatever where you're trying to get into medicine, you just wouldn't have got in the first place. So I think most
Mm.
people sort of will, you have a higher representation of those sort of people just because of the fact that it's hard to get into, but I actually don't think that you necessarily need to be like that to be a doctor. It's just that it's so competitive to get in, that you end
Yeah.
up with some uh, interesting people. I would say I'm a bit of a. I would say I do feel like a bit of an outlier sometimes. I would say that.
Yeah. Yeah. Okay. Why? Why?
Yeah. Uh, I don't know. I guess.
You're a bit more loose, or?
Well, no, not even so much that. More just. I think I've always, even though I was obviously extremely grateful and happy to become a doctor, and I really like being a doctor. I think I guess I just sort of see it as I went through med school and stuff. A lot of people, it was really like such a massive part of who they were was their course and then their job and whatever. Like they really poured everything into it, and that was the main thing that they sort of, it was even like it was kind of like their hobby. Like they didn't really have other things that they liked doing outside of that. They really just poured everything into it. And reaching that next milestone, that next kind of career goal, I guess, was always the thing that was driving them on. Whereas I feel like I've been more sort of, how can this career sort of like maybe serve me? You know what I mean? Like, obviously,
Yeah, right.
I'm still caring for people and I like my job and I try hard at my job, but I mean, I more mean in the sense that like I've sort of made like, I guess, some unconventional like career choices to sort of like uh, move it in the direction that like my lifestyle will be the way I want it to be eventually. So, for example, it's pretty uncommon to do like what I've done, where I did the sort of subcontractor or like locum work for 2 years. And I'm sort of lucky in the sense that I thought that I probably wanted to do GP anyway, where they don't really care so much if you've gone and done that. Whereas the reality is, for a lot of other people, if they, let's just say you wanted to be a surgeon or something, you can't just, go off and travel the world and work a bit here and there for a few years and then come back and talk to the College of Surgeons and say, hey, can I be a surgeon now? They'll say, oh, what have you been doing for the last 3 years? We've got 2,000 applicants here. What sets you out above these 2,000 other people in this last 3 years that you were doing? They've all been doing, advanced research and stuff about surgery. They've been working full time and doing all these extracurricular things to purely just to get onto this program. And you've just been off mucking around for 3 years. You know what I mean? So
Yeah.
it's not something that everyone can do as well.
Yeah. Can you just go back and explain the like contractor work? Because I remember we were telling me about that previously, like I don't know, maybe like a year ago or 6 months ago or something, and I thought that was pretty interesting because I never realized that was even like an option as a doctor.
Yeah. So well, essentially, you can do it in any field or any sort of doctor job, for want of a better word. But I would say one of the more common sort of ways that people will do it will be working in the emergency department, which is what I did. The reason for that is because essentially you're just filling gaps in rosters. So basically, the hospital has, let's just say, 50 full-time employees in their department. And ideally they want to fill all those shifts with full-time employees because they don't have to pay them as much. You know what I mean? But then if, they can't if a whole bunch of people call in sick, someone goes on maternity leave, whatever, suddenly they've got, these holes in their roster they need to fill. And a locum doctor is essentially just someone who works a casual shift. So you're not guaranteed any work. They are under no obligation to hire you or have you in and work. But you just come in, fill a gap in the roster, pick up a casual shift, and therefore, as is the same with sort of any job, if you work a casual shift, you get paid more than if you were to work a full-time or part-time shift, because you don't get all those other benefits and job security, sick leave, annual leave, all those sort of things. But you get a lot of flexibility and you get paid more than you would if you were working full-time.
Yeah. Do you like, because then I wonder about like availabilities and stuff, and like what if like how uncertain is your work, and do you have like a minimum requirement that you would definitely get per week, or is it like some weeks you're just not working, and like, because I feel like that's pretty uncertain. And
yeah, well, that's why a lot of people don't do it. But it kind of depends where you live as well. If you live in Melbourne, you might have 3 major hospitals all within sort of 45 minutes of where you're living, depending on where you are. So between all of those places, they're running a big operation. Like there's a lot of people employed in an emergency department alone, and that's not even including any sort of jobs that they have open up on the ward or in various other departments. So if you lived in Melbourne, you could easily work every day of the week.
Okay.
yeah, like if you were happy to work in a few different hospitals, you could easily work every day of the week, I would say. For me, I moved down to
Mm.
Phillip Island, so it's a little bit more tricky. I was working in Frankston a bit and also in Wonthaggi. Um, I was pretty lucky in the sense that the place I was working at in Frankston, that was actually at a private hospital in a private emergency department, and they would actually guarantee me a couple of shifts a week. So
Nice.
I could work there every Tuesday, Wednesday, and so I had those ones locked in, and then I could just like fill up my roster with other ones on top of that. So I was always
Yeah,
working at
nice.
least 2 days a week, no matter what.
Yeah, yeah, that's so good. So yeah, I feel like that's ideal. Would you reckon you would still have done the like casual contracting stuff if you didn't have the definite 2 days?
Um, yeah, I think I would have done it.
Yeah.
Um, because as I said, it's and to be honest, I feel like it's gotten a lot worse since COVID. Um, people, I don't know. I'll talk about this because I feel like it's an interesting little segue. But
Yeah,
um,
let's do it.
I just kind of feel like before COVID happened, there was much more of a kind of an attitude of even if you're a bit sick, you still come to work. Um,
Mm.
and it's not necessarily that like you were forced to come to work or that it was frowned upon to not come to work, but I think there was just a greater sense of I guess just camaraderie and sort of teamwork in the sense that you don't want to let down the other people on your team by not showing up for work. Um, and then COVID comes along, and when it first came along, they were literally furloughing, basically meaning you can't work for 2 weeks. Um, Hundreds of staff just because they'd maybe sniffed someone who had COVID 2 weeks ago. You know what I mean? Everyone was panicking.
Yeah.
So
Yeah. Yeah. Yeah.
suddenly there's all these staff
Yeah.
being told, oh, if you're even have the slightest inkling that you might be sick or you might be about to get sick or you might have been exposed, then you just shouldn't come to work because, you're putting people at risk. Um, and so I think it's a combination of this sort of from that time where there was that whole sort of attitude of if you're even a little bit sick, you shouldn't come to work because you're putting people at risk. I think the combination of that and also just how sort of bad it was to work in a hospital during that time. Um,
Yeah.
just with all the extra things, just everything was harder basically. With all the PPE and all that sort of thing. People just got, and obviously all the doctors are all still stuck in their houses as well, the same as everyone else when they go home. So
Yeah.
I think a combination of all those things led to this sort of perfect storm where it certainly seemed to me like a lot of people were just calling in sick all the time. Um,
Yeah. Yeah.
and I wasn't the only person who noticed it. Uh,
Yeah.
but I mean, and to be fair, like, you don't know what people are going through. I'm sure a lot of people were going through, mental health problems and all that sort of thing, like everyone else, um, during that time. But it certainly seems like uh, it's hung around as well after COVID. It's kind of like that.
Mm.
It's that sense of, I should do my bit for the team and not come and sort of come to work is kind of gone. And like people, for example, that last 6 months that I was working at Frankston in 2020, well, actually, it was the last 3 months in particular, when I was working night shifts in the Frankston Hospital. So normally during the day, you've got, I don't know, maybe it'd be at least 10, probably maybe even a few more, probably more like 12 or 13 doctors working in the emergency department um, during the day. At night time, you've got like five or six.
Yeah.
Um,
Okay.
and so every single time I had night shift, there would always be like at least one, usually two people would call in sick. So, compared to your, say, if you only got six people, that's a third of your workforce is just gone. And the
Yeah.
people
Wow.
don't stop coming in overnight. They don't know that there's only 2/3 of the doctors that are supposed to be there. So yeah, and it
Eh,
was just I don't know, it was happening very more regularly than you would expect, especially given everyone was staying
Yeah.
at home and no one was really sick because we were all like staying inside our houses.
Yeah. And how do you like handle that when you have people calling in sick and you just like simply have less doctors. I feel like that's like a very stressful environment to be in.
Yeah, I think it depends a lot on how sick the people are that are coming in, I would say.
Mm. Hmm.
Um, because a lot of a lot of problems that people come to the emergency department, I don't know, people have this perception, I guess, that in the emergency department there's just, blood on the floor all the time and, people are dying left, right, and center. But it's not really like that. Most people are actually pretty resilient. Like it takes a usually, even if I don't know. I guess the best way of putting it is you might have a problem that will kill you in like a day or two, but it's not going to kill you in the next 10 minutes, you know?
Yeah, yeah, okay.
So there's a lot of things at sort of that level or below. So it might be, anything from, people have a cut, they could literally, like, they're not going to die unless it gets infected and they get sick, in a few weeks. Or, someone's got appendicitis. It's like, okay, they're sick and they need an operation, but it doesn't have to happen in the next 5 minutes. It's
Yeah,
got
yeah, okay.
got a little bit of time. The times when it gets really crazy, especially if you're understaffed, is if you have, two or three people that are actually really sick and kind of on death's door, so to speak,
Mm.
come in close together. That's when things get totally stretched because yeah, they actually need something done, right now. And if you don't have the
Yeah.
people or the skills or the experience in your team to be able to deal with it, then that can get really stressful. Yeah.
Yeah, because when you say like blood on the floors and everything like that, that's like literally what I was thinking. I'm thinking like ER, like people coming in with like no arm cut off, and like some like crazy
Yeah.
shit going on. What's like some of the wildest stuff you've had to deal with? Or
Yeah.
actually, wait. What's actually so I want to know like the most the most serious, and then also the most like unbelievable.
Unbelievable. What do you mean when you say most serious? As in like someone the most
Like
critical, as in the.
yeah, like yeah, the most critical.
Mm,
The most critical.
all right. I would say the thing that made me the most sort of freaked out in terms of, this is really scary, would have been I actually saw there's like a little baby that came in, like only maybe a month old, and it was sort of
Mm.
potentially about to die. That was really scary. Yeah. Thankfully, I was in a hospital
Yeah.
where they had a pediatric team, so they were able to, come in and work, do their thing, pretty quickly. But I don't know. To be honest, I think that day was actually one of the things that made me realize that I don't want to be in the emergency department forever. Um,
Yeah, that's fair.
that I don't know. There's something about when it's like a little baby, because it's at least if an adult is really sick, you can they're sort of a bit out of it, or they're a bit sorry, someone's driving past with loud music.
That's right. I was just thinking like it's funny how loud that is.
Yeah, they're really blasting it. Um, anyway, sorry. Uh, yeah, I was just saying, like, yeah, when it's a baby, it's extra stressful because it's a baby, it's like this innocent little life, but then also
Mm.
you've got the parents there who are just absolutely freaking out, and rightly so.
Yeah.
So kind of, it's really hard not to panic, I would say, when it's a little baby that's properly sick.
Yeah.
That's really scary. Um, yeah, like I've dealt with other sort of things where people, I guess have been close to death or that sort of thing. But I think that sort of stands out. I would say would be, even though I wasn't having to do heaps myself because there was other people more experienced than me there. I think just yeah, that was probably one of the things where I was just like, oh my god, I feel so out of my depth here. Like this is
Yeah.
this is really scary. Um,
Mm. Have
and
you?
yeah, I think that was a bit of a turning point for me actually in terms of when I sort of realized that I don't think I do want to do this forever in the emergency department because I don't think I want that level of intensity and responsibility um, to all sort of come back to me. Because if you do the ED training, then obviously you're then the person in charge. So any sort of really hard or sketchy thing like that, you're going to be the person who has to deal with it. And I think dealing with those sort of things made me realize, yeah, I don't want to be the person. I don't want the buck to stop with me when a baby that's about to die comes in. And hats off to the people who deal with that every day, because it's pretty serious stuff. But yeah, I would say that's probably the most like, I guess, serious. And then what was the other one? The most funny? Was that what you were gonna say?
And now just the most unbelievable,
Unbelievable.
like just like you can't believe that this is what's happened to them, or
Oh, actually, this one's a good one. This isn't one that I actually saw with my own eyes, but it's a pretty funny story.
yeah, let's hear it.
So I was talking to. This is when I was a medical student. Actually, I wasn't even a doctor yet, and I was on the endocrinology team, and so they deal with all the diabetes sort of stuff.
Okay, yeah, okay, yeah.
Anything hormone sort of related, but one of the main things they deal with is diabetes. And so anytime, basically, if you're a type 1 diabetic, so they're the ones who have to use insulin all the time, like from when they're a little kid. It's not to do with, being really fat and overweight, whatever. It's the one that kids get, where you have to take insulin all the time. Those people if they don't take their insulin, then they get this really dangerous condition called DKA, which basically is when your body, it's to do with basically you don't have access to the glucose like you normally would, and so your body starts metabolizing other things instead, and that then produces acid. So you get acid in your blood, basically.
Wow.
And people get really sick, and they can die from it. And this guy, so I come into placement in the morning, and this junior doctor that I was working with at the time, she comes in, she's like, "You're not going to believe what I just saw this morning." It's like, "What? What'd you see?" And she said, "So I was just down in the emergency department, and we had this guy down there that we see, probably once a week. We see this guy because he's a type 1 diabetic, but he's also addicted to ice. So
Wow.
which is a pretty bad combination. So
Yeah, okay.
he would go out on, these massive ice binges and not take his insulin the whole time. And then he would then end up like unconscious, and an ambulance would pick him up and bring him in super sick into the emergency department. And then they would sort of get him back to sort of the point where he was awake again and like alive. And then every time he'd be like, I need to get out of here. And then he'd just sort of run out of the hospital, basically. As soon as he was awake enough to walk, he would just sort of run out of the hospital and go on another ice binge. And so this sort of kept going on and on and on. And then every time he would come in as well, because one of the things with diabetes is you get really bad vascular problems. And so his toe was becoming like gangrene in his toe and getting really like black and, just nasty. And every time he came to the hospital, the surgeons were like, "Look, mate, we need to cut your toe off. It's going to cause you big problems. You're going to get infection throughout the rest of your body and die, and all these different things." But every time as soon as he was awake enough and could walk, he would bail. And so this one day he comes in, and the doctor is like, yeah. So he comes in, they're getting him from the ambulance stretcher onto the hospital bed, and I kid you not, when they moved him across, his toes fell off.
Oh my god! No, what?
And I was like, what? Yeah. So, and apparently there's a word for it. It's called auto amputation. Is when your limb just falls off without any surgery or anything. It just falls off because it's so decayed and decrepit. It's crazy.
Oh my god! What do they do with the pieces of toe? The toes? Like, do they just bin them, or like?
Yeah, I mean, there's no saving it once it's at the point where it's falling off your body. You're not going to attach that back on. So yeah, probably just put it in the bin. I would have thought. Yeah.
Oh my god! Fuck! I can't believe people leave. I mean, he's also addicted to ice, but fuck! Imagine leaving something like that so long, your toes just fall off. Wouldn't that have
Yeah.
hurt him before? Like, surely there's some pain and discomfort.
Well, maybe not. That's the thing, because um, with diabetes, you like one of the problems is the vascular issues, like your blood vessels get clogged up and that sort of thing. But also, that causes you to lose sensation in usually your toes first. So um, this is sort of why people with bad diabetes typically will have really nasty feet, is because they start to lose the sensation in their toes. Well, I shouldn't say they have nasty feet. If they don't look after their feet, they have nasty feet. But it's because they start to lose the sensation in their toes, and then that, if they don't look after their diabetes, that'll slowly get worse and worse and worse and come up their legs.
Mm.
So they've got bad sensation in their toes, and then they also have bad circulation to their toes. So basically, they might have like even just something as simple as like a little rock in their shoe, and then they just can't feel it because they don't have sensation in their toes, and so they just walk around all day in their shoes with this rock just rubbing away the end of their toe, and then by the time they get home, they've got this really nasty like open ulcer hole in their foot, in their toe, and they didn't even realize. And so then, because they've got diabetes and these vascular problems as well, they're way more prone to getting infected, and it also just takes way longer to heal too. So diabetic people have to take really good care of their feet.
Wow.
Basically, is the moral of the story. Yeah.
Wow, yeah, fuck. I snicker over here because as you're telling me, I just keep imagining that guy being moved from the bed and then his toes just falling off. I can't believe that. I can't believe
Yeah.
it.
It's pretty wild. I'd never heard of that before, but yeah, apparently it can happen if you just
Jesus fuck.
yeah, like every time they'd be like, "Look, we need to cut your toe off," and he'd be like, "No, I'm keeping my toes," and then he'd run out of the hospital, and then eventually his toe just fell off.
Wow.
We shouldn't laugh, but it's pretty funny.
Well, when you objectively, it is a little bit funny, but I'm just gonna
Yeah.
hang on. I just have to turn on my light. I forgot to turn on my light, so give me a second.
Yeah, no worries.
All right, we're back.
We're back.
Yeah, that is really strange. That's really interesting, actually. I wanted to ask before though, about like death. Like, have you had anyone die while you've been working there? And also, like, how do you handle that? Or like, or have you first of all?
Yeah, I have. It's actually pretty surprising, I guess, that there hasn't been, even though I've worked in the emergency department for a while, there hasn't been too many instances where someone's died really unexpectedly, I would say.
Yeah.
Um,
Okay.
That's been under my care at least. So I've had quite a few cases where someone comes in, and they might be, 90 years old, and they're from a nursing home. Maybe they've got a bit of dementia as well. And they've got a bad infection, let's just say, somewhere in their body.
Like what? Like when you say that, like I don't know even what to picture. Like an infection. What is like a typical 90-year-old kind of infection?
I mean, it can be anything. I'd say the two most common would be either a chest infection, like pneumonia, or
Right.
a urine tract infection would be the two most
Mhm.
common, for sure. But generally, those people would present uh, what doctors would call septic, which means they're breathing fast, their heart rate is going faster, their blood pressure is lower, their temperature is high, and they might be a bit more confused than usual as well.
Mm.
And yeah, that would be like a septic patient, meaning they've got an infection that's sort of overwhelming their body basically, and they are likely going to die unless you do something about it.
Right.
So when those sort of people come in, usually for a normal person like you or I, if we came in with sepsis, we would, straight away we go into action. We give antibiotics, we take cultures, we do all these different things to make you better. But there's times where someone comes in and they're, as I said before, like they're 90, they're from a nursing home, they can't walk because they're, and they've got dementia. They don't really even know what's going on anymore. And the family's on board. They've all like done an advanced care directive, which has said like, if Nana gets really sick, we don't want CPR, that sort of thing. And so someone like that comes in. Sometimes in the emergency department, there's like a decision made. You call the family, you have a chat, you say, look, I think, Nana, whatever, probably isn't going to survive this. Her quality of life to start with isn't great. If we were going to try and keep her alive, we would have to send her to the intensive care department. She'd have to have a tube down her throat to keep her alive on life support, that sort of thing. And, basically it's unlikely that she'll survive it anyway. So someone makes a decision that we should palliate that person, which basically means you don't actively treat them, like you don't give them antibiotics, that sort of thing. You just give them, palliative care, like, medicine that makes them not feel pain, not be distressed, that sort of thing. And the family will like come in, hopefully, soon enough while they're still alive. And then depending on where you are in the private hospital, is quite good. Like we can get them admitted to a room in the private hospital, and the family can all come in, and and you sort of, you never know exactly when someone's going to pass away, but you can sort of say to them, look, it's unlikely that Nana is going to survive the next day or two. If anyone, wants to say their goodbyes or something, they should probably, jump on a plane and come and see them, and we'll admit them and give them stuff to make them feel comfortable and that sort of thing. So that is, that's something I've dealt with like quite a few times. So that, I would say it's not, from my point of view, it's not, as sort of super distressing, I guess I would say, compared to, what I was talking about before with like the baby, coming in really sick. Because I guess from my point of view, you see a lot of those sort of people, coming in and out of the emergency department, maybe they might have, been in the emergency department 5 times in the last 5 weeks, you know what I mean? With something else. Their quality of life is pretty terrible. And so it doesn't feel, I guess, like, it just does. Sometimes someone passing away isn't necessarily the worst outcome, as sort of harsh as that sounds to say. It's the truth. Like, and doing something, there's always, as a doctor, sometimes you're fighting the urge to do something. Like there's always the inclination, I guess, that you always want to be the person who's saving someone or doing something, to make them better. But sometimes, as the saying goes, the treatment can be worse than the cure. So, wait, that's not even where we're at, but I said that wrong. But anyway,
treatment could be.
No, I said it wrong. Yeah,
than dying.
The treatment is worse than the disease.
Yeah. Oh, right.
So, like, if we give that example of the person who comes in before, if they've got this nasty infection, if we were to admit them to the hospital, they go to the intensive care department, they're probably not going to survive it anyway, but we just, are giving them all these drugs to try and keep them alive. We've got a tube down their throat, all these different things. The chance of them kind of making it through that is very low. Even if they do survive it, they'll probably be in an even worse state when they come out of it than when they went into it, which was already really poor.
Yeah.
And then also the family that's all around them, their last memory of their Nana is them in the intensive care with, a tube down her throat and all these different things hanging off her, which is, quite distressing for them as well. So, sometimes I guess there's like you've got to resist the urge to do something just for the sake of it. You've got to actually think about the big picture, I guess. And if it was me, what would I want done? You know what I mean? Obviously,
I feel like because you're like, especially because you're you see more of what it's like towards the end of people's lives, and I think for someone like me, who I don't really see many old people like in that kind of state, and I think like, of course, you'd like want to stay alive, and I guess it's like only my point of view, which I am like going off. But I guess, yeah, like when if you were to see these people in these states, it's like it really is potentially far worse of an experience to be like just struggling to stay alive and be there just for the outcome to be worse, if not just like the same. And yeah, it's interesting like how you have to kind of like look at these situations and almost like weighing out the pros and cons of every decision, because I feel like that'd be pretty difficult.
Yeah, for sure. I mean, it's something that, ideally as a doctor, you should be thinking about it anytime you do anything. Is because there's very few things you can do that have zero side effects or zero negative outcomes. It's just you're trying to balance. You're always balancing up. What's the benefit of me doing this, and what's the risk of me doing it? I mean, even something as simple as someone's, say your little 10-year-old kid has got an ear infection. As this is probably something I'm going to encounter a lot next year when I'm doing it, when I'm a GP, is, the guidelines actually say you shouldn't give those kids tablet antibiotics. You should just give them some drops, keep them out of the water, that sort of thing, right? But then, there'll be, people have this feeling, I guess, that my kid's got an infection, they need antibiotics, and they'll come in and they'll be like, why aren't you giving my kid antibiotics? They've been sick with this for, however long, and you're not trying to help them, and blah, blah, blah. And there's a temptation in that scenario to do something just because, I'm a doctor, here's my script pad, like I can do it, I can write a script, even though, there are potentially some, what's the benefit? It's like, all right, well, they've proven that, let's just say that tablet antibiotics don't actually make that much of a benefit. It's pretty marginal. Or, risks, I'm giving this kid some antibiotics, they might get like an upset tummy from it. They might then have diarrhea for the next 3 days because I give them some antibiotics. Or, that's contributing to antibiotic resistance in the community, like we're slowly running out of antibiotics that, bacteria are sensitive to and will work. So there's always, in any decision, even like simple ones, I guess, you've got to try and bring it back to that basic, what's the reason I'm actually doing this? How's it going to help? And, what's the downsides of it? Does the potential upside outweigh any, downside? And ideally you should involve the person or the patient in that. They should know that, because then they can sort of be a bit more involved, I guess, in the decision as well.
Yeah, you mentioned the antibiotics and like resistance. Well, can you explain that a bit? Because my understanding is like we have antibodies in our body, and then naturally, if we get sick or something, our body basically will try to like create a natural antibody that can fight that. But then when we give ourselves antibiotics, that actually like here's my terminology, screws all that up, and can inhibit it, or like make the, I'm just butchering this straight up. You know what I'm talking about. Go straws.
Yeah, I know what you're saying. All right. Well, you spoke about two things there. You spoke about the antibodies in our own, inside ourselves, and how our immune system will fight disease. And then you also asked about antibiotic resistance. So, antibiotic resistance is pretty sort of straightforward to explain, I would say. Basically, you've got, bacteria that is inside your body, or even, we don't even have to take the body into account. Let's just say there's a bacteria sitting in a petri dish, in a lab. If you put a drop of antibiotics on the plate where there's all these bacteria, if it's a antibiotic that the bacteria is sensitive to, that means that the antibiotic is killing the bacteria on the plate, right? If it's a antibiotic that the bacteria is resistant to, that means when you put the antibiotic on the plate, it doesn't bother them. They survive. They keep going. So certain antibiotics are more effective against different types of bacteria. So, depending on what sort of infection you've got, what we think the likely bacteria is that's causing it will give you a different antibiotic because they're more effective against those particular types. Because they work in different ways and the bacteria have different defenses and stuff. So we have different antibiotics that fight different sorts of bacteria. But then over time, what can happen is, I guess an easy example would be on that plate. Let's just say you've got all these bacteria there, and you put some antibiotics on it, but you've watered down the antibiotics. So there's not quite enough antibiotics, or you don't give it for long enough to kill every single bacteria there. So it kills the ones that are really sensitive to the antibiotic. But the ones that have like a little bit of an inherent genetic mutation or something that's like makes them a little bit more resilient to that type of antibiotic, they're the ones that survive. And so then those bacteria they're the ones that survive, so they then start replicating. And so then all the ones that come from those bacteria are ones that are slightly more resistant to those antibiotics that you gave them. Because they've now got that genetic variant that makes them a little bit more resilient to it. And so over time, over like multiple like life cycles of these bacteria, of them like replicating and being killed off a bit, but then like these ones survive and they're the ones that are a little bit stronger. They're the ones that then, it's just sort of like simple kind of evolution stuff where like it's survival of the fittest. If they're constantly being exposed to these antibiotics time and time again, there's an inherent sort of competitive advantage, or what's the word? Evolutionary advantage to a bacteria that has some sort of inherent genetic variant that allows them to survive with those antibiotics around. So in practice, what that means is if we overprescribe antibiotics and we give them when we shouldn't, and we're giving them willy-nilly, then basically you're accelerating that process where, bacteria are being exposed to antibiotics when they don't really need to be, and therefore you're just developing increasing levels of resistance in your community. And we only have a limited amount of antibiotics. There's only we don't come up with a new antibiotic every week. It's pretty. I think they're quite. I don't really know much. I don't really know anything about developing antibiotics. But what I do know is, it seems like it's pretty hard, and they're not able to just pump out a new one every week. So the ones we have are pretty precious, and we can't just use. Yeah.
What's like the impact on that? Like over time, if that keeps happening, and we can't be making enough antibiotics, people are just going to get really sick and sicker and sicker and sicker, or like, and is that even like something that could realistically happen in like our lifetime, or is this like a longer term thing?
Yeah. I mean, there's definitely
it's also like
I couldn't really give you a definitive answer about how soon it would happen, but what I can say is it's already happening. So, for example, if you were to go, like I work with doctors who are from a variety of different backgrounds, nationalities, countries, etc. You talk to, I can't remember, I think the guy I was talking to is Indian, and he was saying that, I'm pretty sure he's Indian. Over there, it's the access to antibiotics is much more, out there. Like, it's way easier to buy them without a prescription, or so people are just, I feel a bit sick, and they start taking some antibiotics. And so over in that community, like already, if someone gets sick, the antibiotics that they will start in the hospital straight away are completely different to what we would give here in Australia, because the amount of resistance to antibiotics in their community is so far advanced to what we've got here. So they have to start, like the antibiotics they'll give people from the get-go are like a lot more, well, they'd be ones that we would use way down the line in Australia if, you know,
Right.
wouldn't be the first thing we'd use. So what I'm trying to say is it's already happening in different places around the world, places where, you know, we've used, way too much antibiotics. There's already a lot of antibiotic resistance developing. And it's here in Australia too, but thankfully we do have some controls in place to sort of try and stop doctors from doing that and stuff. So it's not as bad as in other places. But yeah, I would say it is a legitimate concern for sure for humanity in general. I don't know. I would hope that with technology advancing as it is, that we will get better at developing more antibiotics. But in the direction I think that things are heading, it's certainly a concern. And one of the other things which I haven't mentioned, which also contributes to that, is farming. I think is like a big factor in it. So on farms,
Feeding.
they give farm animals, you know, antibiotics just even when they're not
Yeah.
sick, kind of just so that they don't get sick, so that they grow bigger, faster, and, you know, can then provide meat for the community faster. But that obviously is the same thing, you know, it contributes to a lot of antibiotic resistance in all the bacteria that are hanging out in the farm, which eventually will then that sort of spills over into the human population as well. Is sort of the fear. So I think factory farming is actually like a big player in terms of antibiotic resistance as well. But then I think your other question. Oh, sorry, yeah.
And I was just gonna say, would that mean like as time goes on, once you do get sick, you're actually gonna be getting sicker? Like the strength of whatever it is that's making you sick will have like harsher and harsher symptoms.
Uh, Not necessarily. I think the bigger problem would more be that
You just can't
if you
like
were
fix it.
if you were sick and you needed antibiotics, the antibiotics wouldn't work.
Yeah. Okay.
It wouldn't I don't think that the problem would necessarily be that the bacteria would be more like deadly or more, you know, more
Yeah.
dangerous than what they are currently. It would more just be if your body was getting like overwhelmed by the infection and you were, you know, you're in trouble and you needed antibiotics, it would be harder to find an antibiotic that actually worked. That would more be the problem. Um,
Mm.
does that make sense?
Yeah. Yeah. No, for sure. And I wonder, like,
Yeah.
what's like the healthcare world looking like? Do you reckon in the next like, I don't know, 15, 20 years? Like, what are the biggest things? I know you've mentioned these like these two sort of things as their concerns, but like, what else are we looking in like things to look out for, or like things that are potentially looking really positive? Yeah.
Mm. Um, yeah, I don't know. That's a pretty big question, I guess. Antibiotic resistance, I think, would be a big one.
Mm.
Maybe some other concerns. I think one of the things that I've sort of this is more of an Australia specific thing rather than the world, but I've definitely noticed since we've been in since I've been working in the emergency department, there's an issue with people's access to GPs. So basically, someone is feeling a bit sick, and so for whatever reason, they would normally go see their GP, but um, that GP clinic doesn't bulk bill anymore, so it's going to cost them, I don't know, $50 to go see their GP. So, or they can go down to the emergency department at the public hospital, and it's free. So you
Mm.
have a lot more people showing, and I mean, especially when I talk to my colleagues that have been working for a lot longer than I have, they say there's been like a really big noticeable increase in this in the last few years of just
Wow.
people showing up to the emergency department for really GP sort of problems. Um, you know, things that they normally wouldn't come, but because their GP practice has stopped bulk billing, um, they, or it might just be that their GP clinic is just totally booked out and they can't get an appointment. they're like, oh, well, stuff it. I'll just go down to the emergency department. And so then that then has like all these flow-on effects with the hospital system, because then, you know, your waiting room is, instead of being filled with people who, you know, where, I don't know, let's just say before maybe 50% of the people needed to be admitted to the hospital and 50% of the people could have gone home. Now we've got, you know, a way higher proportion of these people coming in who probably shouldn't have been in the emergency department in the first place, because either they can't afford to go see their GP or the GP is just really busy. So they're just like, oh, stuff it, I can come down to the emergency department, it's free, and, you know, blah, blah, blah. So I'll just do that instead. So I think that's going to be a big, I think that's going to become a bigger problem. Because there's actually a, basically, I don't know if you know this, but in the GP land, I guess, the so your GP, when they get paid, if every time you go and see them, they get paid a certain amount of money from the government, you know, for their services. And so that's how like a bulk billing clinic works. You know, you don't actually pay anything yourself out of your pocket, but they get paid a certain amount by the government for seeing you. And depending on what they did for you, that might be, you know, just the standard amount, or it might be a bit more if they did something more complicated for you. And previously that would go up every year. That would go up, you know, whatever the amount was to sort of adjust it for inflation. But I think it was quite a few years ago now. I can't remember exactly when, but I think it's been at least maybe about 5 years or something. They haven't increased the GP payment at all. So it's been frozen at whatever it was, like 5, 8 years ago. I can't remember the exact amount of time, but it's been quite a long time. And so, especially now that, you know, inflation's gotten a lot worse, the costs of running a GP clinic have gone up, and also the cost of just all the people who work there to go out and buy things has gone up. But the amount of money that GP clinic can actually bring in just from being a bulk billing clinic has basically gone backwards in real terms. You know, especially now inflation's like 7%. They're essentially taking a 7% pay cut every year.
Wow.
And so that's one of the things that you might hear in the news is like GPs complaining about the Medicare freeze. And so that's what that is. So it's been a bit of a long roundabout way of answering your question, but I think that there's going to be an increasing problem in people being able to access a GP in a timely manner and also in a way that they can afford. And then there's also going to be flow-on problems from that in terms of way more overcrowding of emergency departments, and therefore, you know, inpatient, like on the ward of the hospital as well. I think that's going to be a big problem as well.
And what about like when you're, if like you, because I wonder while you're working and say like you're working in the ER and you have like heaps of patients coming in, like more than you could potentially handle, like what's that like on compared to, so what's that like when you are like all good in terms of like your own mental health and your own like personal life versus like if you're having like any like struggling at home or something's going on for you like mentally. Like I'm interested to know like the difference in stress levels as a doctor, especially with like this increase in I don't know, busyness, since people are having less of a chance of getting in contact with their GP, and like because obviously like you're working as a doctor, you know, you need to be like on your game, I feel. But like how does like your own personal and like mental health life impact your days and stuff?
Well, I would say, so I experienced that for sure. I think during 2020, particularly that second half of 2020, was probably, I reckon that was probably my hardest time as a doctor, just because, as I was saying before, you know, workforce problems, lots of people calling in sick, you're wearing all the PPE stuff, like, you know, plastic gowns and everything all day, you're sweaty, your head hurts because the band's like pulling tight, like I've got a pretty big head, so those N95 masks are just cutting into the back of your head, giving you a headache all day. And yeah, just especially the second half of 2020 was, quite busy as well. I think that was hard, but I think it was probably made a lot harder by the fact that we were all in lockdown at the time too. So even when I went home, I couldn't do any of the things that I would normally do to, enjoy my day or switch off or whatever. I was just, stuck in my house in Frankston. So that was probably the hardest time, I would say. Since then, to be honest, I can't really complain just because, as I said, I sort of made that change and have been doing the locum sort of work. So it's, I guess I feel like I'm in charge of my own sort of destiny a bit more, There's something about going to work and knowing that you chose to do it. It's like, I can't blame anyone else for making me go to work. I could have not worked, and I deliberately chose to work today. So I can't really be grumpy. There's no point being grumpy about it because I chose it. So I think, having that sort of flexibility and stuff has definitely helped me a lot in terms of my enjoyment and general sort of positivity about working. But yeah, I think it's important to have something outside of being a doctor, I would say. I think that's probably the best way.
For sure.
And one of the tricky things is that, a lot of people who are doctors or nurses or whatever, they end up dating another doctor or nurse or something like that. So even when they go home, they end up just talking about it all the time anyway.
Yeah.
So that's why I really like that. Yeah, Chloe's not a nurse or doctor because it means that when I come home, I'll literally tell her maybe a little bit about. She'll ask me how my day was, and I'll tell her any sort of funny or interesting things that happened during the day. But then we just talk about all sorts of other stuff. Like I don't get sucked into talking about work and dwelling on it, I guess, when I get home. Plus, I have heaps of other hobbies and stuff that I like to do outside of work. So I think, being able to switch off, I guess, is probably an important way to deal with those sort of things.
Yeah. I want to also know, like, how do you think being, like, working the job that you work, I guess I want to know, like, what kind of impact has your job had on the way you look at life and, like, the way you approach, like, your life just, like, personally? And, like, what's your, like, has it changed the way you look at, like, death and, like, your own, like, life with what you want to do and, just, like, bigger sort of perspective type stuff?
Yeah, I think so, for sure. I think I guess in terms of death, I think, and this isn't necessarily just for someone who's a doctor, I guess for anyone who's seen someone kind of young-ish, I guess, get really sick, it definitely brings things, I guess, into perspective that, our time could be up at any moment. And obviously that doesn't mean that you should, go live in a hut in Alaska or something and or do something super crazy. But I think it is like a good thing to just be aware of, I guess, and remember that, it doesn't last forever. So even though it's good to plan for your future and everyone should do that, you've got to try and find a bit of fun or a bit of, something joyful, I guess, in your day to day. And if you don't have that, you've got to try and find that in something. So I think, that's definitely something that, when it's hard to not sort of reflect on that kind of thing. Like if you see someone, especially a young person, they come into the emergency department thinking like, oh, geez, I've been a bit sick the last few weeks, and now I've like lost a bit of weight too. Like I'm like 10 kilos lighter than I was, 6 months ago, and it's weird. Like I've been eating the same stuff, and they just think that they're fine. They've been super healthy, and then 2 hours later,
Yeah.
they've had a CT scan, and you're telling them, hey, you've got cancer all through your body. It's
Yeah,
hard to
wow.
not sort of reflect, I guess, on the fact that could be you, and
You
that.
I was just gonna ask
But I would also say,
uh
oh yeah, sorry, go.
yeah, I think our connection's making it like lag a bit. No, you
Yeah.
go on and then I'll ask after.
Oh, I would just say the other thing that I guess I've sort of taken out of it is I also get a lot of hope from seeing people who are just have really sort of made an effort to kind of look after themselves, and they're still killing it even when they're really old. So that I really like to see. That gives me a lot of hope. I want to tell you about this guy because this blew my mind. I saw a guy 2 weeks ago, and he was 83 years old, and every morning when he gets up, he cranks out 50 push-ups.
Fuck yeah, nice.
And I was like, that is so sick.
Really, really good.
Yeah, he looked amazing. And it really, that's the other thing that I was sort of getting at is you'll see one person come in who's 83 years old, and they look like that, they've just trashed their body. Like, they haven't looked after themselves at all. They've eaten bad, they've been overweight their whole life, they've smoked, they've drunk, they've eaten crappy food, and it shows. Like, their body is just, falling apart at the seams. And then you see this other guy who's 83 years old, and he's doing 50 push-ups every morning, and he's just killing it. He's super independent, he's strong, he's fit, he's fitter than a lot of like 40-year-olds that I'd see in the emergency department. Wow. And it just kind of shows it on the flip side, if you do really sort of do the right things to look after yourself, your body will kind of, if you're lucky, it'll look after you as well. And you can actually be really vibrant and healthy even when you're old, which is really cool to see. I love that. I love that stuff.
Yeah. As a doctor, what do you do to take care of your own body?
Well, I mean, I guess I've never smoked. That's probably a very straightforward thing that you can do to just, it's bad for you in almost every way possible. So not smoking. I guess alcohol as well. Like I've definitely drunk my fair share of alcohol in my time, but just, on a day-to-day basis, I've never gotten in the habit of drinking every day, which I really like. I like that that's not, because it is an easy habit to slip into. And I like that that's kind of never been a habit of mine. I would all, if there's a party on or something, I have drinks with my friends and stuff. But I think slipping into that, having a couple of drinks every day is like a really slippery slope, and one that can be quite hard to get off as well once you're on that sort of wagon. So that too. I guess a lot of things that I like doing are quite active. I really like surfing, so that's obviously really good for your fitness wise and that sort of thing.
What about your diet?
I'd say that.
How's your diet?
They're kind of the main things. Yeah. Just eating good food, not eating, I mean, it's simple stuff, like you don't have to be a doctor to know these things. I'm sure you talk about it all the time on your pod and everything. It's not like, you need to be some sort of doctor guru or anything to know this stuff. It's straightforward, and anyone can do it, but just because anyone could do it doesn't mean it's easy. Everyone slips up every now and then, but if you just sort of, I guess, actually do your best, then you're probably going to do better than 90% of people.
Yeah, you mentioned before, I just had a question to go back to, which was like, like someone comes in, they think nothing's really wrong, but then like all of a sudden they've got cancer. Like, what is there something that you recommend people be doing in terms of like getting checks or like looking out for? Because like as a 25-year-old male as myself, like I feel fit, I feel healthy, but like, is there should I be at this age, or like what age do you like get checkups every year? Like what's like, you know what I mean? Like, because I feel like for me, there's nowhere really to go. I really feel like, and there's like information of like how I actually should be taking care of my body from going to like a kid to like an adult, because
Mm.
like I don't know,
Yeah.
like, I'm not really being taught that. So like, yeah.
Yeah, okay. Well, I would say as a young man, the only thing that you can really should be sort of checking is your balls.
Mm.
So just literally, what do your balls feel like? Are there any lumps? And just doing that, regularly. That's the main thing, because in terms of cancer and stuff, that'd be the main one you got to look out for as a young man. Um,
Mm.
I guess the other
And
thing
what do
that
those
would be,
lumps feel like? Like, what am I looking
um,
for?
well, basically anything that wasn't there last week or last month, is probably
Okay.
if you're well, yeah. I mean, if you're the stereotypical thing would be something that's hard, and irregular, I guess.
You should say for girls as well.
Okay.
Yeah. Um, but I guess, wait, where was I going with that? Oh yeah. If you're worried about it, then if it feels different, then just go see your doctor, get an ultrasound, and then
Mm.
if there is something there, then they'll be able to find it. And then
Mm.
I guess just, yeah, I don't know if I mean in terms of cancer, that sort of thing, anything where especially if you've started to just lose weight unexpectedly, or yeah, I don't know, you're noticing like really swollen lymph nodes all over the place. Um,
Morning headache.
yeah, that sort of thing I'd say is probably, but I mean, you'll probably know if something's wrong, if something
Mm.
like that's
Mm.
happening. But,
Yeah.
and
Right.
then in terms of if you're a young girl or a young woman, I should say, you mainly, same sort of thing. You should be checking your boobs. So just, and learn how to do it properly. Like, it's not as simple as just like grabbing them. You've got to actually like, feel, smoosh it up against your chest wall and feel the whole way around, making sure that you're, checking the whole area, like right round into your armpit. Um,
Mm.
I'm just sure there's like heaps of videos on YouTube and everything to actually look up how to do it properly, and just
Yeah.
do it, like once a month or something, and then that way, if a lump or something does pop up, you'll actually find it. Because even if you do get cancer, if you catch it early, then there's a good chance that you might be able to save your own life.
Yeah.
And then the other thing for girls would be to get their, cervical screening or pap smears, done. So now
Right.
it's not as often. So it's it used to be, I think, every 3 years, but it's changed now. So it's only every 5 years now. So you don't have to do it
Right.
as
Okay.
often. But
Hmm.
they would be the two main things for a young woman to be checking on.
Hmm. Okay. And what's like? I want to know like what's the most controversial doctor topic?
Controversial for COVID.
Yeah.
Nah,
Like what's? I
I
want
don't
to know
know.
more about your opinion on COVID.
What's my thoughts on it?
Yeah. Like what's more? Like yeah. I want to know more about your opinion on that. Like do you like or even like
Okay.
the general doctor world? Like give me the
Okay.
rundown.
Um. Well, I mean, I mean, it's obviously real. First of all, it is a real thing, and
Okay.
some people do get really sick from it. Um. I guess the the main, I guess, sticking point that I've experienced with myself, talking to other doctors that I work with, is, I think most of I think some of the biggest frustrations, I would say, come from us there being rules that are being enforced that, as a doctor, don't make sense. Um,
Mm.
and it just being like labeled behind this rule of the best health advice, which, every state is using, and that everyone's coming up with a different solution, even though they've all got the best health advice. And I think it's eroded a lot of trust in medicine and in doctors and in like government institutions in general, because they were so worried about people not doing the right thing, or like not, taking it seriously, that they were overreaching with rules that clearly didn't make sense, even to the average person, even if you weren't a doctor. And so and I think the big problem with that is, on a big scale, if, if they're willing to say things like that with such certainty, you know what I mean? Even though it's extremely uncertain or not proven. This isn't talking about the vaccine. This is more just talking about, some of the restrictions and whatever that were going on. If you're willing to say something with such certainty and such, harsh consequences, even when it is so uncertain, it really erodes a lot of trust, I think, in the medical community from the public. And we've felt that ever since the whole COVID thing, because people are like, well, you were saying this before, and then now it's, everyone knows that, that's not true, or like, this is the case. So why should I believe you about this thing? You know what I mean? Like, I think the masks, I guess, this is a good, like, sort of controversial, but not that controversial thing now. The masks, right? So that is an easy one to talk about, because if you wear, so the surgical masks, so those ones that, if you walk into during COVID, you walk into any place, they've got those little blue masks with a little strip across here. The amount of protection that gives you isn't zero. Like, there is some protection that it gives you, but it's really not much from something like COVID. That's just the truth. Like, it'll stop, full-on spit particles landing on someone, but there's so much air escaping all around the mask. And that's the same for the person who's got COVID and the person who doesn't have COVID. They're sucking air in from the sides. The person who's got COVID is coughing and spluttering, and that's all going out the sides of the mask as well. The only masks that are actually make a proper difference are the properly fitted N95 masks. And they're the ones that are like fully sealed. You go and get a fit test in the hospital to check whether it fits your face properly. You're not allowed to have a beard, that kind of thing, because otherwise it's a crappy seal as well.
Wow, yeah.
Like, those ones do work, right? But the surgical ones, they just don't. And the thing is, like, everyone knew that they didn't work. Well, I shouldn't say they didn't work, but they made a very, very minuscule difference. And yet there was really, really harsh, measures, both that we had to deal with in the hospital and the public had to deal with out in the community, even though it was making like hardly any difference. And I think that has taken a big toll on people's trust in people like me, I would say.
Yeah, okay.
I think, do you know what I mean?
Yeah. Do you feel like, I want to know, like, how does that make you feel as a doctor? Like, I feel like, to be there, like, trying, like, serving the public, and then because of these higher up decisions, they've impacted how now the general public, which you were trying to serve, they make, now they look at you negatively. How does that feel?
Yeah. It's definitely frustrating. I would say, I'm not, if I can, if you can see an obvious benefit in doing something, even if it's, a bit inconvenient for yourself, I can understand the rationale. Like, all right, yeah, we don't want me being sick, coughing on Nana, giving them COVID. Obviously, that's bad. We don't want that. But what I think was lost during the COVID era, and even still to this day, is people are have been more concerned about making sure that things appear as though we're keeping COVID out, rather than actually doing the practical steps that are most, cost efficient, just make the most sense. Like I'll give an example, right? So in an emergency department that I worked in at one point, there was a rule that you had to wear a surgical mask, which are the ones that I said before. Like there's studies showing that they make a really hardly any difference to the transmission of COVID.
Mm-hmm.
So you had to wear those at all times. So when you were sitting at your computer writing your notes, when you were talking to a nurse, when you went and saw the patient, at all times you had to wear one of those. But there was no rule about when you should wear the N95 masks, which are the ones that actually work. So it's like, if we're actually serious about stopping COVID, transmitting between me and the nurse I'm talking to, then we should both be wearing N95 masks, Or if we're serious about stopping COVID spread between me and the person who's sick, or them giving me COVID, then we should both be wearing N95 masks. But instead, we're all wearing these masks that don't really do much. And I could still get COVID from the nurse. She can still get COVID from me. I can get COVID from the patient. You know what I mean? So, or the third option would be, which is what would make more sense, in my opinion, is you have if someone comes in with like COVID symptoms, anyone who goes in and sees that person wears an N95 mask, and the person who's got the symptoms wears an N95 mask. And then when you're outside of that room, like, you don't have to wear one. That would be my personal preference, but I'm not a hospital director person. But it's like, if what we're really trying to do here is stop COVID, why wouldn't we do the thing that we actually know works, which is the N95 mask, rather than just like giving the illusion that everyone's safe from COVID by us all wearing surgical masks, even though they actually do hardly anything. It's like, which is it? Are we actually trying to like bring COVID transmission in this hospital down to zero, or are we like, do we not really care about it that much? You know what I mean? It's like people are just doing the easy option that makes everyone feel good and look good, even though it's not actually having any real practical benefit.
Sort of,
and it makes me frustrated.
Like they're doing
to answer your question, yes, I get frustrated.
Yeah. Do you like? Because you hear, I guess, or I hear at least, like the government's doing all this stuff to be more controlling, and like there's talks of like potentially like new I don't know what to say, like legislation, but like new rules and policies that allow for like more control and stuff, and like where the world is going. And there's like this like general kind of topic that I hear sometimes on the internet where like it's about like the government controlling the people and like making them sick. Is that like, do you reckon that's like a real thing? Like,
Yeah. I would say no. I mean, there's a few different sort of conspiracy theories kind of wrapped up into one there, but like, I've heard some people say things like, "Oh, the government, they want people to be sick because they make money when people are sick," or something like that. Like, I've heard people say that to me, and that is just pretty ridiculous in my opinion, because I mean, the money that is spent on healthcare in this country is absurd. Like, if you can look it up, I don't know how much it is, but if you looked up what the health budget is, it's massive. Like, politicians aren't making money as far as I know, they're not making money by people being sick. You know, there are people that make money from people being sick, but it's not politicians. Doctors make money from people being sick, but also,
Yeah.
we don't. Enough people get sick anyway. Like, we don't need to be making people more sick to get ourselves more business. Like, that's not really our thing.
Yeah.
I guess some people might choose not to believe that, and that, because doctors, I guess, technically make money when people are sick, that we would then try and keep you sick. But personally, I haven't seen that. I haven't seen,
Yeah. Right.
I would say there is a little bit of a, as I sort of said before, there's like a tendency to do something. Like, if you go and see a surgeon about a problem with your foot, like, they know how to do operations. So, like, there's a higher chance that they'll be like, oh, maybe you should get an operation. You know what I mean? And that doesn't necessarily mean it's bad advice or that you shouldn't get the operation, but it's like they're less likely to, I guess, see it from the point of view of like a physio or someone who makes money from you doing rehab. You know what I mean? Like, if you go and see a physio, it's more likely that they'll say, oh, do these exercises and, we'll see how you go, whatever, and try and keep you away from the surgeon. Whereas the surgeon is like, oh, yeah, here's this problem. I can fix it. Let's do an operation. That's not to say that they're all like that. There's a lot of really good physios out there that will say, this is outside my scope of practice. You should go see a surgeon because you need an operation. And there'll be surgeons who say, I'm not operating on that because, I might make it worse and you really need to go do exercises instead. So there's good surgeons, and there's, I guess, more money hungry surgeons, I guess you could say, for want of a better term. But I don't think it's necessarily coming out of like a really dark place. I think it's just, people have a set of skills and they think they can help you with their set of skills. And so they think that's the best way forward. It doesn't necessarily mean that they're evil or that they're wrong. It's just like that's their skill set and they think they can help you with their thing. And so they try and do it. What I would say is that there's definitely in terms of like pharmaceutical companies and stuff.
Yeah, that's my next question.
Yeah, like, people can be very, I think, reassured in Australia, the fact that we have a lot more restrictions in place in terms of, what would be the word, like handouts or, I guess, what's the word? I don't know. I'm looking for not bribes, but that sort of thing from pharmaceutical companies.
Yeah, I was going to say bribes.
Yeah, like that doesn't. I mean, there's a lot of regulation about that in Australia, and as far as I know, the most that I've ever seen is like a pharmaceutical company might buy a bunch of food and bring it into a hospital at lunchtime and say, hey, you guys can all eat all this tasty food if you like listen to my half an hour presentation about this, new drug. That's like, honestly, that's like the extent of it that I've ever seen in my like 5 years or whatever of working as a doctor. That's like as far as they can take it. Basically, it's like, here's, we'll provide, your lunch today if you listen to us for half an hour about this. I've seen that happen a couple of times, but to be honest, I don't think that's necessarily that bad, really. I mean, obviously, they've got an agenda. They're trying to sell something, but it's, I don't know. I mean, you could argue that it's bad, but it's certainly not, people getting all expenses paid holidays to Hawaii or something like that. And, there's nothing like that going on that I've ever seen or heard of. I think it used to be able to happen, but not for a long time. But like in the States and stuff, I think there's a lot more problems with that sort of thing.
Yeah.
And
I feel like that's
would say,
really what...
I would just, there's one other thing I thought of. Sorry.
No, it's
I was just going to say, during COVID, like, that's sort of one of the things that, I don't know, I guess the conspiracy theory sort of people are like, oh, the government is like in cahoots with the pharmaceutical companies, and that's why, the vaccine was, purport is the only solution or whatever. And I mean, I don't know whether that's true or not. I suspect probably not. But one thing I would say is I think like there was a huge opportunity missed in the sense that, you know, you had this moment, right, in where the entire country was so scared of getting sick, and they were kind of willing to do anything to get better, or to stay healthy. Like everyone was literally willing to stay under house arrest for like 6 months, basically, to not get sick. And so I feel like there was this huge opportunity missed where they could have run this huge like public health campaign to be like, you know, this is how you need to eat to, you know, to get healthier. This is what you should be doing in terms of exercise every day. If you're smoking, you should stop it, because all these things are going to make you way more likely to die from COVID if you get sick, compared to almost anything, any other factor. Like if you can eat healthy, lose any excess weight, stop smoking, your chance of dying from COVID, you know, can drop significantly. But, you know, I just feel like there was this whole opportunity missed, and instead we just said, you know, nah, just stay in your house. You can maybe go out for like 1 hour a day, and everyone just got sad,
was fucked,
lonely, and fat, and drank way more alcohol and got way more unhealthy. Which then made them more likely to die from COVID. You know what I mean? It's like, I don't know. I feel like there was a big opportunity missed, in that sense.
What would you, if you could change one thing about like the healthcare system, what would it be?
Oh, that's a hard one. Could change one thing.
Or a couple things if you want.
Yeah. All right. I think I'm not sure exactly how to do this. I think paying. I mean, I'm obviously biased because I'm about to become a GP, but I do think paying, unfreezing the payments to them would help. As I said before, I can see that problem only getting worse and worse in terms of it overloading the hospital system because people aren't going and seeing GPs instead. But I would also say that somehow that like it's important to do things to make sure that like the services that GPs are providing are actually good, because I think everyone's had, you know, a crappy bulk billing clinic experience where like you go in there with a proper problem, and anything that doesn't require, you know, a script or a referral to someone else, they just don't want to hear about it, and they just automatically, you can feel that they're just trying to fob you off to someone else, and it gives, I guess, the whole profession a pretty bad rap. And I do think I'm not sure what to do to kind of disincentivize that sort of, I guess, business model, but I do think that paying people a little bit more to spend more time with people would be a good step. Those places, their whole business model is how many people can we get in and out in an hour, to basically make this worthwhile to not charge people extra money. And so they're just, anything that's going to take longer than 8 minutes or something, they're just trying to, you know, either fob you off to the emergency department or a specialist or whatever. And I think it kind of, that is kind of bad for the whole system, because it's just creating unnecessary extra cost and extra waste of time for the person, and it's, you know, you're not really fixing many problems as well, which could have been fixed in the GP clinic. So I don't know. I hope that I can help with that myself, at least a bit, in my small way.
Yeah, it's interesting. I feel like there's just like it's like such a I mean, there's like our world in general, right? Our society in general is just like so complicated. There's like so many problems everywhere and so many difficult problems to solve. like where do you even fucking start? You know, like healthcare is like one thing, and then you just have like all sorts of other shit feeding into
Yeah.
this, and people's then you just have like people in general, like their own habits and like their relationship with themselves, and then like that just makes things more difficult. You know, it's like you almost
Mm.
need to change people from like within themselves to like have good habits, have like a better understanding of like how shit works and like how they maybe should be living and treating their bodies, and then like just like everything could be maybe a little bit easier, you know? And like teaching our kids, I feel like I didn't really get taught much. I feel like as a kid about like health at school. I don't know. I feel like I really didn't get taught much.
Mm. Yeah, I think I've realized more as I've gotten older, like how much of how lucky I was in terms of my upbringing, like my parents and stuff. It's sort of there's things that
Yeah.
you don't realize when you're a kid are like actually making you a good adult. At the time, it seems kind of stupid, but then or
Mm.
like it's just normal. But then you realize later, like, oh, all these other people didn't have that, and now they have all these habits, whereas I have all these good
Yeah.
habits because it was just normal for me to do that when I was growing up. It's things as it's simple stuff too. It doesn't even have to be really crazy things like just brushing your teeth. Like if
Yeah.
your
Yeah.
parents have, um, just from when you're a kid, it's like a non-negotiable thing that,
Mm.
morning you brush your teeth, night you brush your teeth, and then you have good teeth. It's like, whereas if you're a kid, like no kid cares about brushing their teeth. The only way that they start caring about it is if their parents make them care about it. Like that's the only way.
Yeah. Yeah.
And then, but it's even in other things too that I've kind of realized as I've gotten older, habits that I've picked up when I was a kid. Like I remember my parents always saying like, "Oh, you've got to have something green on your plate." You know, no matter what,
Mm.
no matter what meal it was, like there would always be something green on the plate, and it was just always a thing. Like, oh, hang on, we need to have some. There needs to be something green. Like, there's always something, and you realize
Mm.
when and then like it's in there somewhere, and then when you're making dinner, you're like, all right, I'm doing this and that, and then you're like, oh, there's nothing green. Like, I need to have something green in my dinner. Like, I don't know, um,
Yeah.
just yeah, it's hard because I mean, obviously people have it's a free country, which is awesome, and people should be able to raise their kids however they want. But yeah, those sort of like simple public health, I guess, kind of things, just stuff that encourages kids to yeah eat. This sort of stuff isn't very good for you, and this stuff is really good for you. Um, just teaching that restraint and kind of moderation, and I don't know. It's a hard thing
Yeah.
to do on a big scale, I think.
Oh, for sure. And I think like, I mean, for me, it's like when I see it sucks when I see like some like young kid who doesn't know any better or anything like that, and they're just like super overweight, or like their parents are obviously just letting them eat like whatever, or they're feeding them like junk food and McDonald's and shit, and I just feel so bad for like the kid, because then they grow up and they're 15, 16, 17, and now they're like fat, they're really obese, and it's like, oh my
Mm,
god, like they're not doing exercise. And I mean, same with me. Fortunately, I grew up in like wasn't really allowed to eat junk food. Like my nonna cooked like all of our meals, like homemade meals, like just that was I was super active. But like that's just because I was luckily enough born into a family that did that, you know?
mm.
So it's just like
Yeah, exactly.
sad to see, I think, that kind of treatment for kids. It's almost abusive. I would you could argue that is almost abusive.
Yeah, but yeah, it's a hard one because I mean, there's no
Lack of education.
that's the thing they say, like there's no license or test or anything you take before you can have a kid. Like
Yeah,
it,
yeah, yeah.
people are just doing it and they're having kids and there's it doesn't come with a manual as they say. So, that it doesn't necessarily mean that the parents are bad people or anything, but they just don't know any better themselves. And
Mm,
I mean, I haven't had any kids yet, so I can't really speak with any authority on parenting. But yeah, it's pretty clear that if you let your kid eat curly whirlies all day, that they're gonna not be very healthy. Um,
yeah. Yeah. I got like one of my final questions I tend to sort of like end on, which is I want you to imagine we have 1 million people listening to this right now, and I want to know like what you're saying to these 1 million people.
What am I saying to 1 million people? This is like my final words kind of thing, is it? parting words.
It is.
I would say, it's good to try and plan for the future as though you're going to live until you're really old, but also try and find some fun in every day, so that if something does, happen to you or something like that, that you know that you're enjoying your life right now as well.
I like it.
Yeah,
I like it. They're always good. These 1 million people questions, they always bring out some good shit.
yeah.
It's true. Fuck yeah! All right, awesome. Thank you so much, Straws. This was awesome. This is,
no worries, mate.
super insightful, super interesting, and I appreciate you coming on.
No worries, mate. See you later.